On behalf of The Hindu, I extend a warm welcome to the panelists and participants to another episode of Wellness Webinar on Understanding IVF and Fertility. Today's webinar is presented by Kauvery Hospital in collaboration with The Hindu to mark the World IVF Day, that is In Vitro Fertilization Day, which falls tomorrow on July 25th. Infertility among couples is a growing concern today, and the doctors will explain the types of fertility treatments and also provide guidance on IVF, the most common form of assisted reproductive technology. As you can see on your screens, we have a big panel, and so let me start right away with the introductions of our speakers. Our first speaker is Dr. Gopinath, Director, Reproductive Medicine, Kauvery Hospital, Vadapalani. He will speak on the evolution of infertility treatment. A well-known gynecologist and obstetrician in Chennai, specializing in IVF and fertility preservation, Dr. Gopinath has over 3 decades of experience in his field, during when he has successfully treated numerous couples, helping them to realize their dreams of parenthood. He has done this by providing cutting-edge IVF treatments and care. Dr. Gopinath's expertise is in the latest advancements in IVF technology and techniques. He ensures personalized care tailored to each person's unique needs. Dr. Gopinath has won multiple awards, including the National Fertility Award in 2024. A warm welcome to you, Dr. Gopinath, and over to you.
Thank you. Greetings from Kauvery Hospital, Vadapalani, to all of you who have joined this webinar and the panelists and Suma. Can I start this talk?
Yes, sir.
Yeah.
You could start your present slides also.
Yes. See, we all has been just saying, what is this World IVF Day? So if you go through this history, you will see the in vitro fertilization is a process by which an egg is fertilized by the sperm outside the body. That is in vitro. Actually, it is evolved as a major treatment protocol for subfertility. The term in vitro is from Latin word meaning a glass, which is used for all the laboratory items containing the beakers, test tube babies, and petri dishes there. So if you look through 1890, they have, from the Cambridge University, they have transplanted embryos into the rabbit. So in 50, Min Cheng has done the first time achieved a live birth where rabbits were used for egg and sperm of black ones, just to make sure it is differentiated.
So may I interrupt you? So are you moving your slide?
Yes, I am
because
moving.
Because it's not showing. It's on the screen.
Now?
It's static.
Now?
No, sir.
No, I'll stop and share it again. Is it visible?
Yes, sir.
Is it moving?
No.
Not yet.
Yeah, it's moving?
Yeah, it is. It is.
Okay.
It is, sir.
Fine. So, in 1973, Carl Wood and John Leonton has reported the first human IVF pregnancy, but it has resulted in an abortion. In 1976, Patrick Steptoe and Robert Edward reported an ectopic pregnancy following an embryo transfer. And this is that famous man, Robert Edwards, and he was born in 1925 in England, pursued his degree in agriculture, then switched into zoology. He has completed his PhD in 1955 on the mouse embryos and artificial insemination and infertility in the University of Edinburgh. In 1968, he started his journey along with Dr. Patrick Steptoe on the research of human in vitro fertilization. I had a very happy occasion to share some joyous moments with Patrick Steptoe when I was on the training there. And the history of IVF, the first IVF baby was born on 25th July 1978. It is from a natural cycle IVF. The patient had a blocked tubes and the baby was named as Louis Brown. So you will see that lovely Louis Brown, the baby's photo. And this is the Patrick Steptoe and Robert Edwards who have delivered the baby along with the Jean Purdy, who is the staff nurse there. So from then on, he was awarded Nobel Prize in 2020 and for the development, which has helped in millions of infertile couples. So this baby, Louis Brown, now you see she's a grown-up lady who is married, and then she has also produced two lovely children through a natural conception. Her first boy was born in 2006. The second boy is about 2012. She has delivered two children normally. If you look into our country, in July 16, 1931, Subhash Mukhopadhyay was born in Hazaribagh in Calcutta, and he had worked as a physiologist in NRS Hospital, Kolkata. And after he has done a lot of work, and then he has produced the first test tube baby on 3rd October. It was born to the Prabhat Kumar and Bela Devi Agarwal, and he has published his paper, but somehow it was refuted. It was not accepted for a long time. Later on, as early as about 2019, it was accepted. And then that was probably the second test tube baby in the world. And Harsha was born under Dr. T.C. Anand Kumar from IRRC in Bangalore, where the father of the India's first test tube baby. 16 years later, the Sunil Kumar showed him the Mukhopadhyay's notes saying that they're all sure, and then they were worked up there.
So you have to once again put your screen on full screen mode, your slides on full screen mode.
It is moving in the full screen now.
Okay. I think we are still stuck on.
Now?
Yeah, now it's come.
So,
yes.
This is the man, hails Dr. B.N. Chakravarti, is hails from Kolkata, was a pioneer and delivered the third IVF baby, Imran, and he established a well-renowned infertility center called Institute of Reproductive Medicine, trained several stalwarts of today in his center. Even I was one of the persons who was trained under him in 88, and he sent me abroad to Australia in 89. Some of the very good moments where he was down in Chennai, and then he has produced some of his good talks there. What is the significance of World IVF Day? It is a teamwork. 1 in 6 couples probably may require. It depends upon the patient selection, proper indication, stimulation of the ovaries, retrieval of the eggs, insemination, looking for signs of fertilization, monitoring and development of the embryo.
So your slides are getting stuck. I'm sorry to interrupt again and again.
Now is it moving?
Yeah. We have come to significance of World IVF Day.
Yeah, that's what I was just talking about.
Yeah.
This is a teamwork involved, all these items which has to go through that. And this is various his timelines where it all started from 1984, gradually produced up to that latest ICSI, which has been started in 2020. From, if you look into the 94 to 97, 99, there are various developments has taken place in the IVF there. Now we have come to the 3 parents baby. What is 3 parents baby? Mother gives the oocyte. From there, a donor egg is taken. From the donor, cytoplasm is transferred back into the mother's nucleus, and it is fertilized by the father, and then the baby is produced. This is called three-parent baby. This has been significantly for any mitochondrial dysfunctions, it has been done there. There is something called fertility preservation. Patients who have been diagnosed as a cancer in the reproductive age group, they have to undergo chemotherapy and radiotherapy, which will destroy the ovarian tissues. So before the start of the chemotherapy and radiotherapy, fertility preservation can be offered. It is in the form of a oocyte cryopreservation when the woman is not married, when she is married in the form of an embryo cryopreservation, when she is a small child before puberty, you can take the ovarian cortex tissue and cryopreserve. So, in those who want to postpone the child for various social reasons can also preserve that oocyte, which is called as social freezing. In case of severe diseases like endometriosis, etc., the fertility preservation can also be offered. The ART expectation about right now, more than 12 million babies is born through ever since the first test tube baby was produced by Robert Edwards. Prospects hold promise for rapid revolution of ART. Time lapse has helped to select the embryos and avoid expensive invasive tests like PGD, and newer drugs where gives better ovarian stimulation, egg quality, and implantation rates there. To conclude,
Sir, have you put your presentation on full screen mode?
Yes.
We are still stuck on the same slide.
So now it is in full screen mode. Hello?
No, sir.
Is it on the full screen mode? To me, it
No,
shows
sir.
as only a full screen mode.
But okay. We have come to the end of your.
This is the last slide. So, cost and complexity of the treatment has been reduced today. The risk of multiple pregnancy has been nearly solved there. Newer techniques in the management of severe male factors where no sperms can be sort of produced by the man, where it is called non-obstructive azoospermia. We can do some biopsy, take out the sperm and just give him a healthy child. Detection of genetic abnormalities before the embryo transfer is possible. Further refinement with the ongoing use and practice of ART is there. Fertility preservation has been focused in indicated situations. So the concept of IVF day theme, educate others about scientific breakthroughs in the reproductive medicine, discuss infertility issues and raise awareness about infertility prevention and treatment, and promote future research on further things. This will be the theme for IVF Day. And we are celebrating the pioneers of IVF. Thank you very much.
Thank you, Dr. Gopinath, for that comprehensive talk. We'll now move on to our next speaker, Dr. K. Shanmuga Vadivu Venkateshan. She is a senior obstetrician, gynecology, endoscopic surgeon, and reproductive medicine consultant with Kauvery Hospital, Salem. Trained under experts from India, France, Germany, USA, and Egypt, she has over 3 decades of expertise in obstetrics, gynecology, infertility, IVF, and embryology, and has played a key role in introducing several advanced fertility and uterus preserving procedures in rural Tamil Nadu. Dr. Shanmuga Vadivu's clinical practice focuses on high precision gynecological surgeries, endoscopic fertility enhancement, and advanced reproductive care. She has performed over 10,000 laparoscopic and 15,000 hysteroscopic procedures and is known for delivering the first IVF ICSI baby in 2020 in Kallakurichi in rural Tamil Nadu, where she has also been instrumental in establishing the first NABH entry-level IVF facility. She says her goal is to increase awareness and access to high-quality fertility care in underserved regions and promote uterus-preserving procedures to improve long-term health in women. Subfertility in women is the topic of her presentation. So welcome, Dr. Shanmuga Vadivu.
Thank you, Soma. Good morning, sir, Gopinath sir, and good morning, Ramya ma'am and Divya ma'am. Nice meeting you all in this platform. Looking forward to have a lot of interactions with you again. Let me start sharing my screen. Madam, is the screen is full?
Yes, ma'am.
Yeah. So I took this topic, infertility in women, because this is a broader topic wherein infertility implies medical intervention. In subfertility, there is a possibility of natural conception. So I thought this will be useful for the public also. That is the reason I took this topic. What do you mean by subfertility? It's a reduced ability to conceive, resulting in longer time to achieve pregnancy compared to the average group of women. So, what is the difference between subfertility and infertility? In subfertility, there is a delay in conception, but the woman has still the possibility to conceive without a medical intervention. And it's a delay, not an inability. So, what do you define as infertility? It is a disease of men and women when a couple who have been trying to conceive with unprotected intercourse without success for at least 12 months of time, after which a formal investigation is justified and medical treatment is implemented. So the key aspects of fertility is delayed conception, prolonged time, and there is reduced fertility, and the couple is less fertile. So before to make the public understand, I am just showing the anatomy of female reproductive system, wherein the important aspects of reproductive system is uterus, tubes, and ovaries. And uterine mouth is also important because it's also called as cervix, because it is the entry point of the sperm. So let us talk about the problems, because most of the problems are mechanical, which can be corrected in subfertile people. So there are, we can start with ovulation disorders, that is the problem-related egg production. So there are two types of problems in common in women. One is PCOD, commonly told as polycystic ovarian syndrome, wherein patient has a lot of eggs, but the eggs are ineffective. And recently we are seeing a lot of premature ovarian insufficiency patients, wherein the eggs are low. Even the eggs are low, because of that, the eggs are ineffective. And coming to the tubal causes, because tube is the most important part in the reproductive system, because it is the meeting point of the sperm and egg, and any damage or blocks caused by any infection, endometriosis, or any surgery near the tubes might affect the tubal function. So the next we are talking about uterine diseases. It includes diseases like acquired diseases like fibroids, adenomyomas, and any problem with the lining, that is we call as endometrium. So any thinning of the endometrium or overgrowth of endometrium, also called polyps, may interfere with the conception. And the abnormally shaped uterus, also called Mullerian anomalies, will also cause a lot of problems in conception. So we are just highlighting the uterus, uterine mouth, also called as cervix, because any problem in the cervical mucus or presence of anti-sperm antibodies will prevent the sperm from entering into the uterine cavity to reach the ovum through tubes. So the most important factor is the age of the female, because the fertility declines after 30 years. So there are also some subtle ovulation defect as a cause. There might be subclinical pregnancy losses. We call it as biochemical pregnancies, wherein the patients will be positive for pregnancy, but the pregnancy doesn't continue. There might be endometriosis involving ovaries, also we call as chocolate cysts. There might be an undiagnosed infection. There are immunological causes which will prevent pregnancy. And also there is unexplained infertility, and even recurrent pregnancy losses come under the category of subfertility. So how do you assess the female subfertility? We can take a history. about when the patient attained her periods, the regularity of the cycle, and past medical and obstetric history. We can take social and sexual history and the habits like alcohol and smoking, and any previous infections like chlamydia or gonorrhea. And any by doing physical examination, we can find out any problems like endometriosis, which will cause severe pain while examination. And any basal investigations for the female like FSH, LH, estradiol, all those things I'm not going to detail. And most importantly is the test for the ovarian reserve. The important tests are anti-Mullerian hormone tests in the blood. It is called AMH. And AFC, that is antral follicular count, is done by the scan, wherein we see the basal egg stock in the ovaries. We can even assess by seeing whether there is any impaired glucose tolerance and high cholesterol in patients, and we can take vulvovaginal swabs to see any infection. And the tubal disease and uterine diseases can also be assessed by hysterosalpingogram, wherein we inject a dye and an X-ray is taken. And we can, if warranted, MRI or CT scan is required to assess any problem centrally, that is in the pituitary gland. And only the diagnostic hysteroscopy and laparoscopy will be for confirming the findings which we are suspecting. So then when we come to the management of each problem, so ovulation disorders, as I told you about PCOS and premature ovarian insufficiency, PCOS can be tackled by managing the body mass index or lifestyle management, by medical treatment, or else by surgery through drilling surgery. And poor ovarian reserve doesn't have a definitive treatment as such as for now, but latest injection of platelet-rich plasma prepared from patient's own blood injected into the ovaries is giving good results. And we can also advise freezing the eggs if the reserve is low. And tubal diseases are common cause in women because of the and we can also clear the tubal blocks by hysteroscopy. And if the severe blocks are called hydroscalpings, if it is the block is very severe and causing any difficulty in any future procedures, laparoscopic salpingectomy may be advised in unavoidable situations, especially when an IVF cycle is planned. So then managing uterine pathologies has become easier because of hysteroscopy. Hysteroscopy operating hysteroscopy has given a lot of solutions for all these problems. Like even the congenital anomalies can be corrected by hysteroscopy, and acquired pathologies like fibroids, polyps, all these can be tackled with hysteroscopic procedures. And most importantly, as I told you earlier, the uterine mouth, also called cervix, if it is inflamed or infected, there may be a problem. For that, we assess it with pap smear or colposcopy. And the solutions, like we can do a cryocautery or loop electroexcision to clear the problem. And always we say a clock is ticking in a woman's body in the form of age. So the peak fertility period is at 25. It declines thereafter. So if the women are planning family life later after 30 years, it's better to freeze their eggs. So how do you improve the fertility in women? It's tips to improve fertility in women. It is by lifestyle changes, dietary adjustments, also medical interventions whenever necessary, achieving healthy BMI, engaging in exercises, moderate exercises, avoid excessive exercises. So embrace a fertility-friendly diet, and also avoid all excessive caffeine, sugary drinks, and alcohol. And stress is the most important factor in women also, so which will help to manage the hormones. You can track your ovulation by tracking your fertile window, and also by assessing the cervical mucus. And regular intercourse, if we can track your ovulation, is advised. And avoid any harmful habits like smoking and drinking. Whenever you need a professional guidance, please take the advice if your age is more than 30 or 35. So when do you consult a fertility consultant? Women who wish to get married after 30 years, you should do it because to know your egg stock and consumption capacity. Women who wish to start a family life later can discuss about freezing their eggs. Young girls and women suffering from irregular periods, absent periods, decreased periods, definitely they can have a scan. They find out the problem of PCOD or premature ovarian failure. And women having intermenstrual bleeding, heavy bleeding lasting more than 7 days, having clots or severe pain in periods, definitely they can do an ultrasound scan to find any abnormalities. And even a diagnostic hysteroscopy or laparoscopy might be helpful. And women with chronic low backache, especially more at the time of period, they should definitely do a scan to rule out any adenomyosis in the uterus or any infection. And definitely any woman who never had a positive pregnancy test within 1 year of marriage should definitely consult an fertility consultant. So thank you so much.
Thank you, Dr. Vadivu. So we are midway through the presentations, and I would like to request our audience to start sending in their questions. The Q&A box is open now. Our next speaker, Dr. Ramya Praveen Chandar. She's consultant reproductive medicine and IVF specialist with Kauvery Hospital, Radial Road. She's an expert in counseling infertile couples, and having trained under pioneers and stalwarts of reproductive medicine in the UK and India, it is her accurate scrutiny of the exact root cause of male and female infertility with appropriate investigations and treatment that is acknowledged by all. She has helped couples of all ages to conceive successfully via assisted reproductive technology. Dr. Ramya believes in helping couples with poor ovarian reserve and poor sperm parameters to conceive with their very own gametes wherever possible. She skillfully manages couples with recurrent IVF failures and multiple pregnancy loss to conceive via advanced fertility services. Dr. Ramya will speak on intrauterine insemination. Welcome, Dr. Ramya.
Good morning, all of you. Thank you so much for a warm introduction. Is my slides visible?
Yes.
Okay. So today, my topic for today is insights on intrauterine insemination. So, which we call it as IUI. So this is one of the basic and simplest fertility treatment in assisted reproductive technology. It is considered as first therapeutic step in the treatment of infertility. It is a outpatient procedure and it is a patient-friendly procedure as well, and it is similar to the natural conception. So what is intrauterine insemination? So it involves the placing sperms directly into the female uterus in order to increase the chance of fertilization. So it is otherwise called as artificial insemination. So how does IUI increases the chance of pregnancy? So in natural conception, so sperms has to travel from the cervix to uterus and finally it reaches the egg. So in natural conception, basically the cervix naturally limits the number of sperms that enters the uterus. Only a small percentage of sperms enters the tubes. So in IUI, the sperms are directly placed inside the uterus, bypassing the cervix. So it has to travel only for the shorter distance to reach the egg. So number of sperms reaching the eggs are higher. So it increases the chance of pregnancy. So IUI can be done with husband sperm as well as with husband sperm. There are two types of IUI. One is with the husband semen and donor semen. Who requires intrauterine insemination? First, these are the female cause of IUI. If the female has ovulatory dysfunction, that is in case of polycystic ovarian syndrome, we advise for IUI. In case of mild endometriosis, unexplained infertility, where the cause of infertility is not known, And in case of cervical factors such as cervical stenosis or any previous surgeries done in cervix can cause scarring and can lead to infertility. And in case of vaginismus. In male factor, when there is abnormal semen parameters, that is when the semen count is low, or when there is severe sperm poor motility or very poor sperm morphology, and in cases of sexual dysfunction like erectile dysfunction or ejaculatory dysfunction, hypospadias, where the penile opening is seen under the organ, retrograde ejaculation, where the ejaculate goes back into the bladder when the husband stays away for long period. These are the indications for donor insemination. When there is semen analysis showing azoospermia, where there is no sperms for the male partner, when there is genetic factors that genetic disease can transmit, where there is transmission of genetic disease to the child, single women, same-sex couple reluctant for IVF, patients reluctant for IVF and ICSI, and in case of severe abnormal sperm factors. So there are two types of IUI. One is natural cycle IUI and medicated cycle IUI. In natural cycle IUI, it is based on women's natural menstrual cycle. It is useful in women with proven natural ovulation and couples who are unable to have sex. In medicated cycle, fertility medications are given to stimulate the ovaries and increase the chance of ovulation. This can be given in the form of oral or in injectables. These are the steps involved in the intrauterine insemination. First, pre-treatment workup is done, followed by controlled ovarian stimulation, and then ultrasound monitoring of the ovarian responses, and ovulation is induced, and timing of IUI is planned, followed by semen collection. Semen is collected from the partner, sperm preparation, followed by intrauterine insemination and post-insemination follow-up. In pre-treatment workup, we do hormone profile like follicle stimulating hormone, luteinizing hormone, thyroid function test, and prolactin. And we assess the ovarian reserve by antral follicular count and AMH. We screen the couple for serology like VDRL, HIV, HBsAg, and HCV. And tubal status for the female partner is assessed. At least they should have one patent tube. And the semen analysis shows sperm count should be more than 10 million per ml. This is the process of IUI. Serial transvaginal ultrasound is done from day 9 to monitor the growth of the follicles. Once the follicles are ready, the trigger is given, which prompts for ovulation in and around 36 hours. So timing of IUI is planned. Ideally, it is done between 36 to 40 hours after the trigger, or after the confirmation of ovulation in the scan. Then semen is collected. It is done 2 hours before the insemination procedure is scheduled. It is collected through a masturbation in a sterile container. Then semen is prepared through a process called sperm washing that pulls out only a concentrated amount of healthy sperms. This is the insemination procedure. So patient lies on the examining table, and the clinician inserts a speculum into the vagina to look for the cervix. Then a catheter is inserted through the cervix into the vagina, and the washed semen sample is slowly injected. Post insemination, patient can lie down for 20 to 30 minutes, and luteal support medications are given, and urine pregnancy test is advised 2 weeks after the intrauterine insemination. So factors that helps in removing the IUI result is, first is controlled ovarian stimulation. By doing controlled ovarian stimulation, we get more oocytes, subtle ovulation disorder is corrected, and accurate, and we can time the ovulation. And then second factor will be semen preparation. It selects the most active sperm fraction by removing the dead cells, debris, prostaglandins, and seminal plasma. This media as such provides nutrition, and it improves the sperm motility. And third one is the insemination. Insemination is done bypassing the cervix, so it increases the density of the sperms in the uterus. The average success rate is around 10 to 15%. This is the age-wise success rate. So if the female partner is less than 35 years, 13% chance per cycle. If she is between 35 to 37, then it is 10% per cycle. If she is between 38 to 40, then it comes down to 7% per cycle. And if it is more than 40 years, then it goes down to 4% per cycle. So around 80% of the pregnancies occur within first 3 cycles. So if the couple has not conceived in first 3 cycles, then they need to be counseled regarding advanced treatment options like IVF or ICSI. So harmonic cycles can be done with IUI. So pregnancies resulting from IUI can occur during first 3 to 4 treatment cycles. So pregnancy rate drastically drops from fourth cycle. So at least maximum of 3 consecutive controlled ovarian stimulation with IUI should be performed. So these are the risks with intrauterine insemination. Immediate risk can be mild cramping and spotting or bleeding, and late risk can be infection, ovarian hyperstimulation syndrome, multiple pregnancy, and pregnancy complications. So these are the factors determining the IUI success. It depends upon the age of the female partner, ovarian reserve, cause of infertility, duration of infertility, and the post-was recovery of the total motile sperm count. So what are the benefits of IUI? It is cost effective, easy to perform, less side effects, and no anesthesia is required. It is totally a painless procedure, minimally invasive and uncomplicated procedure. So take home message will be IUI is an inexpensive, non-invasive and painless procedure. So it is effective in couples with unexplained infertility and mild male factor infertility when it is combined with ovulation induction drugs. Success rates varies with the patient profile. So younger women will have higher chance of success with multiple IUI cycles. Thank you.
Thank you, Dr. Ramya. Now on to the final speaker, Dr. S. Divya, consultant fertility specialist, obstetrician and gynecologist, Kauvery, Trichy. The youngest member in the panel, she has a very brief introduction to. Dr. Divya did her MBBS and MS from PSG Institute of Medical Science and underwent training in laparoscopy and hysteroscopy. She's well trained in obstetric ultrasound and ART too. She also has a master's in clinical embryology from Australia. So over to you, Dr. Divya, for your talk on IVF and related procedures.
Hello, can you hear me?
Yes.
Okay. A very good afternoon. Thank you for the kind introduction. Today I'll be focusing on what is IVF procedure, how we do it, and what are the indications for IVF procedure. And this year's theme for IVF is celebrating hope and advancing science. The slide moving?
No, it isn't.
Okay. Okay. To make it more interesting, I would like to brief about a small history, which the IVF procedure has been explained in our history like Mahabharata, where in Gandhari's story, she was given a boon by sage Vyasa and she became pregnant. After that, she had a prolonged pregnancy for about 2 years, but even then she did not deliver. But after 2 years, she delivered a lump. What they did is, this sage Vyasa, he divided this lump into 101 different pieces and then he incubated in different pots with adding some ghee, and that's how Gauravas were born. So this is something which is similar to IVF procedure, which was told in our history in Mahabharata itself. So the first son of Gaurava is Duryodhana, followed by 99 sons, and she had one daughter. The story was talked about even 7,000 years back. But now we are talking about IVF pregnancy, which is just happening in the last few decades. Our first IVF baby was born from 1978. So this is just a brief, interesting history behind this procedure, which was talked about in our history several thousands of years back. So I'll be focusing more about how these artificial reproductive techniques are done. So these techniques starting from IUI, which madam she already talked in detail about, which also comes under artificial reproductive technique, where we handle all the gametes outside our body. Because in IUI, we handle the sperms outside our body. That's why we include even IUI under artificial reproductive technique. Then comes the in vitro fertilization, where the fertilization part happens outside our body. Then comes the ICSI. It is a technique where we do the fertilization. So in IUI, as already they've explained, is just a catheter where you prepare the semen sample and put inside the mother's womb, timing the ovulation. That is IUI. In IVF, what we do is we stimulate the patient. We give lots of hormone injection for about 10 days. And here you can see in this picture, you can see lots of stimulated follicles. The daily injections are taken by the patient, or they come to the hospital and take injections for about 10 to 12 days. Once you see a mature follicle, all the follicles should be around 18 to 22 millimeter. Then we do the trigger shot, and after that we plan for oocyte pickup. So how we retrieve the egg? What we see in the ultrasound is only the follicle. We don't see the oocyte, which is a very microscopic structure. So once we aspirate using ultrasound, we retrieve the egg and then we give it to the embryologist, where they will identify the egg and the quality and all, and they will let us know. By then, we'll ask the husband to give the semen sample also during the pickup procedure. So once we get the sample, the embryologist will fertilize the egg and the sperm in a dish, and then they use the technique like ICSI to make the embryos get fertilized. So it will be like this, like a single stage. Post fertilization, we can see like two pronuclei in the embryos. Then it divides into two cells. This two cell becomes four cell. Four cell becomes eight cell. So this is the eight cell stage that we call as day 3 of the embryo. Sometimes we freeze day 3, or the day 5 of the embryo is called as blastocyst. So after freezing, we time the embryo transfer. Either we can do fresh, that is, we do the egg retrieval. Following that, we can do embryo transfer, or we freeze the embryos and then do frozen embryo transfer. So just it's ultrasound procedure, which is done quickly. We don't need any anesthesia. So we do the embryo transfer and give adjuvants and make the patient wait for about 2 weeks. And we ask them to do a pregnancy test after 2 weeks and confirm whether they are pregnant or not. So once we do the embryo transfer, we ask the women to continue all the medications what we prescribe post embryo transfer, which will support implantation, and then ask her to do beta HCG test. So for whom we should opt for IVF is if they're undergoing IUI procedure, which is a day care simple procedure, as madam already told about. If you're facing so many failures of IUI, I've seen many patients coming with 5-6 times failures. So those are the patients, they should step up for IVF. They should not hesitate to go for IVF. And those already have bilateral tubal block because of any infection, tuberculosis and all. And if they're having unexplained infertility with IUI failure, that is, there should be some reason for the gametes not getting fertilized inside the body. We are seeing follicles coming up, we have the sperm, but the pregnancy will not happen in spite of having all the tests are normal. So those people will come under unexplained infertility. So for them also, we can opt for IVF. And severe male factor, where some patients will not have sperm or very low sperm count, they can go for directly IVF, even though the female is normal. And some patients also come with poor reserve, that they don't have the adequate follicles for the simple treatment. And in some cases where some patients will have absent uterus, or some uterine problems where they would have undergone lots of uterine procedures. So for those patients also, we can opt for IVF. So in conventional IVF, what is IVF is in vitro fertilization. We take the sperm from the husband and the egg is collected in the dish, and then we just make the sperm to naturally select and then get fertilized. That is called in vitro fertilization. This is only termed as IVF. The technique is we are selecting the sperm and then injecting into the oocytes ICSI. We have various methods to select a sperm. This is intracytoplasmic morphologically selected sperm injection. That is, if you see in this, the equipment has around 8,000 magnification power, where you can make out even a small vacuole in the sperm, and we zoom it and then select the normal sperm before injecting into the oocyte. So this is a ICSI technique where you can see the sperm we are taking inside the pipette, and the needle is getting injected into, this is the oocyte where we take from the female, and then the sperm is injected into it. This is the ICSI technique. In PICSI, this is also another technique where we have another dish with hyaluronic acid, where we put the sperm in that, and the normally selected normal sperms will go stick to this hyaluronic acid. So we take that selected sperm and then put it inside the oocyte, so that we increase the chances of getting a good quality embryo. Piezo ICSI is a artificially AI technique where it injects the sperm. So it is better than the conventional ones. Here the embryologist does the injecting part, but here the AI does the injecting part. That is the difference between piezo ICSI and the conventional ICSI. So IVF is actually a safe procedure. So many they get scared to go into IVF thinking that it is artificial. So IVF has helped millions of people worldwide to have children. Most people undergo IVF with no complications. So we have so many advanced techniques in IVF, medication protocols to improve the outcome and reduce the risk. So IVF is a safe procedure only. So sometimes the patient can develop OHSS, for example, in a PCOS patient, or during egg retrieval, there might be some complications like bleeding or injury to the adjacent structures, or the patient might get emotional or psychological stress if she's facing any previous failures, financial burden. So these are some of the psychological things which can happen during the treatment. Or sometimes you can have multiple pregnancy, which itself is a risk factor. So sometimes because of this injecting technique, birth defects can happen. It is not that it is risk free, but we will be screening the patient like any other patient during anomaly scan. We do fetal echo to rule out the birth defects. And because of this multiple pregnancies, sometimes twins or triplets can cause premature birth. And because we are doing the injecting part, incubating in the incubator, sometimes genetic diseases can happen. That is the epigenetic changes, which can lead to some of genetic diseases. So how we maximize safety for patients who are undergoing IVF procedure is, always when you plan to go for IVF treatment, you have to choose a reputable or accredited fertility clinic or a doctor whom you trust. And then you have to follow proper medication and monitoring schedules as you have been instructed. And then you discuss the embryo transfer numbers, the quality with your doctor to reduce the risk. So nowadays we are moving into single blastocyst transfer to reduce multiple pregnancies, so that single baby is the ideal one even in IVF pregnancy. So you have to consider counseling if she is already having any mental health issues, or if she's undergoing any stress as a couple or the patient. We should also give the mental health support during the treatment to maximize the safety during the procedure. So IVF is a safe procedure. So ideally, I think people should opt for it when it is not working in a simple treatment. I see most of the patients, they're scared of IVF treatment because it is artificial, not natural. But if it is indicated, if they're falling under an indicated group, is the best treatment for them to get a baby. So thank you all for your patient listening.
Thank you, Dr. Divya, for your presentation. We have very little time left, so I'll just straight away hop onto the questions, and quite a few have come in. Doctors, all of you have discussed the treatments, fertility treatments quite a bit in detail. So Purushothaman Venkataraman is asking, what are the major reasons for reduction in fertility in the present population? And what is the remedy, if any? So, Dr. Gopinath, you have to unmute yourself. Unmute.
Okay, I'll take this question. See, the importance is there is a fertility is almost the same, but here there is a fertility awareness is there. Previously, they used to wait for about 6 years, 7 years, and then come for treatment. Today, all the basic needs are fulfilled at the earliest. Say they get a job, they get a house, and they get a car, and then they want the baby immediately. So there is an awareness is there that more of things are coming out. On the male side, the smoking, alcoholism, drugs, chemicals, pollutants, all this has reduced the male overall count to a reasonably smaller extent, contributing to male factor. For female, the lifestyle modifications, junk foods, and not no exercises, high BMI, and then delay in childbirth because of the other social and professional reason has caused an increase in infertility. If you want to concentrate on improving the fertility in this, the general lifestyle modifications, good diet, exercise, no junk food, for this will be the ideal thing to preserve that fertility.
I think lifestyle modifications and all healthy habits are applicable to diseases across. So
Yeah.
anyway, yeah. All of you have also discussed about, a certain amount or percentage of failures in IVF. So Dr. Shanmuga Vadivu, one would like to ask you if there are any particular risks involved in IVF. Unmute yourself. Doctor, unmute yourself.
So IVF as such doesn't have any risk in experienced hands. So the risk is only actually from the selection of the patients. Actually, we have to select the patients, and we have to be very frank and open regarding the fertility prospects of the couple. And if they are having any less number of oocytes, and you have tried all the treatment, and you have to tell the probability of the success. And as such, in the procedures, there is no risk in the experienced hands as such.
So no side effects,
So
no risk
the
as
patients
such.
have to, yeah. The patient has to understand their key problem, and it should be usually very well made. The patient understand better. Actually, they have to understand better about their fertility. Like if the younger the age group, it is better. The older the age group of the couple, they have to definitely understand their problems, and only the risk is on the patient's monetary side, because they have to be explained well about their problems and then take a call.
Dr. Ramya,
regarding-
actually a lot of doctors have joined the webinar, and Dr. Ramya, I would like to take this question for you. Somebody's writing, I am an MBBS doctor from Coimbatore, and I have a hard time explaining my patients and referring them after preliminary fertility tests. I would like to understand the probability of success rate of IVF procedures. Basically, I think how to deal with the patients. Yeah, not patients, sorry, people who come for.
Yeah, for IVF, the success rate in IVF depends upon the age of the female partner. So as the age increases, the success rate in IVF decreases. So, and it also depends upon the cause of infertility and duration of infertility. Yeah, so in cause of infertility, if it is done for mild male factor, or in cases of unexplained infertility, or in case of PCOS, the chance of success rate is higher. Where in severe male factor infertility or severe endometriosis, the chance of success is little bit lesser. So the average success rate depends on average success rate in IVF is around 30 to 40%. Again, it depends upon the patient profile also.
Dr. Gopinath, I think in between you, because your slides were not visible, so an anonymous attendee is saying, could you please once again quickly repeat the 3-parent baby and social freezing? And also, if freezing eggs is an option, but how common it is?
Yeah, normally a cell has a nucleus and mitochondria. The same way, an egg has got a nucleus and mitochondria. If there is a mitochondrial disease, what do? We take the eggs out from mother, take the donor egg, transfer the mitochondria into the mother's egg. And then use the husband's sperm to fertilize. This is called 3-parent.
So you please, we can come back to the question then. Yeah. Dr. Divya, may I ask you, like, Dr. Shilpi Sarkar is asking, how is uterine fibroids and ovarian cysts treated? How are uterine fibroids and ovarian cysts treated?
Actually, it depends upon the site and the size of the fibroid. If it is subserous, that is outside the cavity, it will not affect much. But even then, the size also matters. If it is huge fibroid, like 7 centimeters, 10 centimeters, then it is better. What we do in IVF, if the patient wants IVF, then we collect the oocytes and then freeze the embryos. We do the myomectomy, and then we give a period of 4 to 5 months for the fibroid wound to heal, and then we transfer the embryos. It depends upon the patient. Suppose the fibroid is inside the cavity, submucous fibroid, we should actually remove the submucous fibroid before doing embryo transfer. So if the size is only 2 to 3 centimeters, it is there in intramural, seedling fibroids, small ones, you need not disturb these fibroids. You can avoid surgeries in these type of patients. So it depends where the fibroid lies and the size of the fibroid. And if the patient is having repeated failures before myomectomy, then we can suggest myomectomy and then do embryo transfer. So it depends upon patient to patient, this thing. And ovarian cyst, if it is endometriotic cyst, but you're planning IVF, you need not remove the endometriotic cyst. You can just collect the embryos and then do embryo transfer. Provided we should avoid puncturing the cysts.
Dr. Shanmuga Vadivul, James Paul wants to know how common is male infertility or extremely poor healthy sperm count in the general population, and what are the options for patients with such issues?
Can you come again?
How common is male infertility basically, and what are the options for patients?
Actually, male infertility is on the rise and it is being for so long because it's mainly due to the lifestyle. Because most of the men travel a lot, sleep less, and especially in the IT sector, their food habits are erratic, obesity, and basically they don't exercise. And any person sitting in the same place, they have the increase in that total temperature and a lot of other things. So the thing is, the lifestyle modification is very important. And I used to say to my patients that it's better any male person definitely has to undergo at least one semen analysis before marriage to see everything is okay. Because if it is a very severe form of male infertility, the patient has to be definitely be aware of his problem. And anything like once he gets married, the treatment option should be started as early as possible. And if for example, if the patient has no sperms in the semen, so it doesn't mean he cannot give a baby. He might definitely, there are treatment options wherein he will have good sperms in his testicles. So actually, there is many male patients ask me also, is there any tablets to improve the sperm count? There is no such treatment to increase the sperm count, but except for the lifestyle modifications and some sperm vitalizers or the sperm, the vitamins for the sperm. That's all. So it is basically for men has to definitely change their lifestyle, have a good sleep, drink plenty of water, avoid wearing tight dresses. Better to have. That is why in India we all wear dhotis, because dhoti is designed for India because of the temperature. So the one has to understand that all these factors play a lot of role, and there are some wrong myths in patients also that not ejaculating for a lot of time will help them to improve the sperm count. No. So the at least once in 2 days, either they have to ejaculate, either having some time with his wife, or else even in the bathroom he can ejaculate it. The holding of the sperm doesn't take him doesn't give a healthy semen actually. So a lot of main thing I will advise is for any men in this era, better have at least one semen analysis before considering having a child.
Dr. Gopinath, you're comfortable now? Would you like to go back to the question?
Yes. See, the cell, the ovum, has got a nucleus and then it has got a mitochondria. The mitochondria may be defective. So, how do we do? Get the patient's egg, take a donor egg, take the cytoplasm from the donor egg and inject it into the woman's egg, the patient's egg. So it contains the nucleus, that is the genetic material from the wife, and cytoplasm from the donor. So this egg is injected with the husband's sperm. So practically you will see the genetic material nucleus from the wife, cytoplasm from the donor, sperm from the husband. This is what is called as a three-parent.
And how common is social freezing? And there's also a related question from Yasmin Fatima, who wants to know, is it possible for someone who has never been sexually active to undergo egg freezing?
Yes.
Are there any additional considerations or precautions to be taken in such cases?
Egg freezing ideally done within 30 and 34. So this is the time, if they don't have a partner or if they are not planning, they can do. Even for a woman who is not sexually active, she can go ahead, then freeze their eggs. The social freezing was remote. Before 2012, it was considered experiment. But today, her highest body, ASRM, says it is a routine clinical practice. It should be offered. And we are getting cases for social freezing.
Dr. Divya, Madhumita Vijay Kumar says that she has irregular periods and has undergone 6 IVFs, out of which 2 failed, but the other 4 were successful. But all 4 had spontaneous abortion at 7 weeks. She says, I have even tried donor egg, but the same 7-week spontaneous abortion happened. And now she's 37 years old. So what should be her treatment line?
Genetic counseling, and we can do PGT, pre-implantation genetic testing. We should identify why she is getting early abortions. So we have to rule out the cause, and then we have to streamline the treatment for that particular patient.
So that will be only through genetic.
Maybe genetic or any other APLA, or so many reasons are there for early abortion.
I have a word. Actually, definitely there is also a possibility of assessing the uterine cavity. As I told you earlier, there might be some problem in the shape of the uterus or any abnormal defects congenitally in the uterus, which might not be truly addressed actually. And if you can find any abnormality in the cavity of the uterus, it can be corrected by hysteroscopy. And latest treatment of injecting PRP into the uterus has definitely improved the conceptional rates, especially for the people who are getting repeated abortions. And in fact, in my own experience for the past 5 years, I have seen patients who are having repeated abortions being benefited with correcting the uterine cavity, as well as using PRP injections for the patients who's having recurrent implantation failure or recurrent pregnancy losses.
So, somebody is asking if are there any specific instructions on containers and transfer of sample to hospitals if the semen sample is collected at home?
Number one, it should be collected at the place of examination. That is the best option. If it is being collected outside, first thing is that IVF center or a semen analysis place, they have to register and record it. It is not collected in the premises because you have to, the anonymity is there, the genuinity, the identification factor is there. So what if they bring something else, So that is the reason we document it, and the patient just signs it saying that they have collected at home and brought it. It is their responsibility. And then about the container, normal semen analysis is somewhere between 1 to 5 ml. We have to give at least about 50 to 100 times that of a volume. So 100 ml wide mouth, non-toxic, has to be given to the patient to collect it. Ask the patient to open the lid, close it, and then again take it home and then collect it there in the house. And once when the collection is done, it has to be transported to the body temperature, which is about 37 degrees centigrade. So in that sense, ask him to put it in the pocket and bring it rather than putting it into different containers, refrigerator, ice. That is very, very important.
Going back to the previous question, Dr. Divya, Kavisha wants to know that in case of existing genetic disorder in the female, what precautions need to be taken during egg freezing or IVF?
See, in any genetic disease, we have to screen both the partners, male and female. We have to identify what type of genetic disease is this. They should undergo proper genetic counseling. So, according to that, we can tailor what type of PGT should be done. We have so many things, aneuploidy, PGTS, and so many things, genetic thing and all. So, once they undergo genetic counseling, they'll get the clarity what to be done, because each test, according to the genetic analysis, the cost of the test also goes high. So it is always better that we screen both the partners for the genetic disease, undergo genetic counseling. Then you can take a decision along with the doctor whether this can be done in the embryos. After doing genetic analysis, then they can transfer the embryos if it is normal.
Dr. Shanmuga, if a couple is in their 20s, how long should they try natural conception before approaching fertility treatments?
So definitely not less than a year. So with regular unprotected intercourse and being together for a year. And after 1 year only, they should definitely come for the test. But if at all the patient has any problems, as I told earlier, if the wife has irregular periods or scanty periods or absent periods, and if the man definitely he wants to have any checkup or anything like regarding the semen analysis for routine, he can have it. They can have a routine screening. There is no hardcore rule that they should not come for any. There's nothing wrong in having some basal scan for a woman and basal semen analysis for a male before waiting for 1 year.
I think we have really overshot our program time. I'll end with one last question. Dr. Gopinath, what is the cost for IUI and IVF treatment approximately in our country?
So approximately for an IUI, it should come somewhere around 15,000 rupees, which will include the medicines, the injections, scan, and then the sperm preparation and the insemination procedure. And cost of an IVF ranges from somewhere around 1.5 lakhs to 2.5 lakhs. Why the range is, it is mainly on the drugs. If you are going to use a human menopausal gonadotropin, which is a cheaper drug, and if you are going to use a recombinant FSH, it is going to be costly. And then it depends upon the patient's age and the ovarian reserve. Some people will require only about some 2,500 units totally. Some people might shoot up to about 4,000 units. So depending upon this requirement, there is a range somewhere between 1.5 lakhs to 2.5 lakhs is the average rate.
Okay. So thank you, doctors, with all those valuable inputs from the experts on the eve of World IVF Day. We will wind up the webinar on IVF and fertility presented by Kauvery Hospital in collaboration with the Hindu under the Wellness series. So thank you very much, Dr. Gopinath, Dr. Shanmuga Vadivu, Dr. Ramya, whom I can't see on the screen now, and Dr. Divya for sparing your time amidst your busy schedules. And thank you, audience, for joining in such big numbers and sending in those questions. Thank you all.
Thank
Thank
you.
you so much.
Thank you.